Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach. I tutor for Step 1 and Step 2, and today we'll be reviewing a Step 2 CK pediatrics question. So let's start by reading the question. A 9-month-old boy presents to the emergency room with 2 days of fever, fussiness, and irritability. His mother reports he has not been feeding well and has only had one wet diaper in the past 24 hours. He had one small, non-bloody, non-bilious emesis this morning after feeding, but otherwise has no other symptoms. He was born at term and has no other medical problems. He is uncircumcised. His temperature is 39.2, heart rate is 170, respiratory rate is 40, and blood pressure is 92/50. He is fussy but consolable, and the remainder of the examination is unremarkable. A catheterized urine specimen is collected, and the urinalysis reveals the following. A urine culture is pending. What is the best next step? So I'd like you to pause the video for a moment and try to work through this question on your own first. So welcome back. So let's work through this question together. So the first thing we should do is look at the actual question itself. What are we being asked to do? So what is the next best step? So this is going to be a question about management. And then we glance at the answer choices, and we see that some of them involve additional diagnostic studies, some of them involve imaging findings, and some involve medications or a combination of the two. So we don't need to spend too much time here. We just glance at them and we get a sense of what types of answer choices are going to be available. And this helps frame how we approach the question. So this should only take a few seconds. So this is going to be a question about management. Remember that in boards questions, these are often two-step questions. The first step is to identify the diagnosis, and the next step is to answer a specific question about the diagnosis. So let's read from the start and highlight the important elements. A 9-month-old boy presents to the emergency room with 2 days of fever, fussiness, and irritability. His mother reports that he has not been feeding well and has only had one wet diaper in the past 24 hours. He had one small, non-bloody, non-bilious emesis after feeding, but otherwise has no other symptoms. He was born at term and has no other medical problems. He is uncircumcised. His temperature is 39.2 Celsius, heart rate is 170, respiratory rate is 40, and blood pressure is 92/50. He is fussy but consolable, and the remainder of the examination is unremarkable. A catheterized urine specimen is collected, and the urinalysis reveals. So before we move on to the urinalysis, let's interpret a few of the findings. So I want to point out a few things. So the first is that this is an infant presenting with these nonspecific findings of fever, fussiness, and irritability. And it's important to remember that infants this age cannot communicate their specific symptoms. They cannot communicate that they're having headaches or visual disturbances or abdominal pain, nausea, or that they're having pleuritic chest pain, whatever the symptoms are that older kids might be able to communicate, and definitely that adults would be able to communicate, infants cannot. So we rely on these very non-specific findings such as fussiness, irritability, inconsolability, lethargy, somnolence that the parents report. So whenever you see this, it should be a clue that the infant is sick or ill, because that's the only symptom that the parent would really be able to communicate. So fevers plus these nonspecific signs such as fussiness or irritability should be concerning for an underlying illness or infection. We can also throw in poor feeding in there, because that's one of the few things that infants do pretty reliably. So if they're not feeding well, it's also a sign that they might have an underlying illness or infection. It's also important to point out that this child has only had one wet diaper in the past 24 hours. So although you don't need to know exactly how many diapers infants should have at each age, as a general rule of thumb, they should have at minimum 2, if not 3 wet diapers in a 24-hour period. So at least 2 to 3 is kind of the bare minimum for infants in terms of urine output. So having one wet diaper in the past 24 hours gives us a sign that he's having poor urine output and is likely a bit dehydrated. So then we keep reading. He has one small episode of non-bilious, non-bloody emesis after feeding. And in infants, remember, infants spit up all the time. And if it's just one small episode, it has non-concerning features, it's non-bloody, it's non-bilious. This is pretty unremarkable, especially in the setting of an infant who has a fever and who's not feeling well. So this is not too unusual. Now, if there were repeated episodes, if they were projectile or forceful or were bloody or bilious, this would be concerning. But just one episode by itself is not unusual for a febrile infant. There are no other symptoms. So there are no other GI symptoms like diarrhea, there's no cough, there's no upper respiratory symptoms, nothing else that the parent reports. Now, in terms of past medical history, he has no significant past medical history. The only thing that's remarkable is that he's uncircumcised. And this is really important because we'll point out a little bit later on why this is important, but hold on to that thought for now. So he's febrile, 39.2. His heart rate is 170. So this is slightly elevated for a 9-month-old. We can use, as a general rule of thumb, 160 as the upper limit of normal for infants less than 12 months of age. And the respiratory rate is still within normal limits, slightly higher on the upper limit of normal, but still within normal limits. And the blood pressure is as well. So as a general rule of thumb for blood pressure for children aged 1 to 10, the normal systolic blood pressure is typically going to be around 90 plus 2 times the age in years. And this is approximately the normal systolic blood pressure, and you can say up to 10 years of age. We can say 0 to 10. So up to 10 years of age, you can use this as a general rule of thumb for approximating what the systolic blood pressure should be approximately. And here we can say he's about 1 year old, so it would be around 90 to 92 would be the normal blood pressure. So his blood pressure is in the normal range. So in terms of the vital signs, the ones that are remarkable are that he's febrile and slightly tachycardic, and that can typically be seen in the setting of fever as well as dehydration. And we get the sense based on his urine output that he may be a little bit dehydrated. Otherwise, he's fussy but consolable, but the remainder of the exam is unremarkable. So we can assume that there are no other focal examination findings, including the lung findings were normal. There were no upper respiratory signs such as nasal congestion or throat erythema or throat lesions. The belly was soft, non-tender, non-distended. We can assume when they tell us that the examination is unremarkable, that there were no other findings on exam that were concerning for a focal infection. Then they tell us that a catheterized urine specimen is collected and the urinalysis reveals the following. So let's go through this urinalysis. Let's work through this together. So first, it's important to point out that this specimen was collected via catheterization, and we'll talk about why that's important a bit later. So the specific gravity is on the higher side, which is consistent with the fact that he's only had one wet diaper in the past 24 hours, so a touch dehydrated. And we have the presence of 10 to 15 white blood cells, which is elevated, no red blood cells, positive leukosterase, and positive nitrates, and the rest is unremarkable. So the combination of the white blood cells with the leukosterase and the nitrites is concerning for the presence of pyuria, which is white blood cells in the urine. So let's pause and let's put all of these pieces together. So remember, for the two-step questions, we want to first identify the diagnosis and then go on to answer a specific question about the diagnosis. So putting these pieces together, we have a 9-month-old, previously healthy, uncircumcised male presenting with 2 days of fever, fussiness, poor feeding. Objective fever is measured with some mild tachycardia and an otherwise unremarkable exam with a urinalysis that is has the presence of white blood cells in the urine altogether, this is concerning for a urinary tract infection, especially because this is an uncircumcised male. And so that is one of the risk factors, in addition to infants less than 12 months of age, for a urinary tract infection. So it's important to remember that you can have white blood cells in the urine, and it could be something else. It could be Kawasaki disease. It could be one of the glomerular diseases where you get white blood cells in the urine. But in the presence of the fever, plus the fussiness, the decreased urine output, and the risk factors, where this is a infant less than 12 months of age who's uncircumcised, all of those put together are very concerning for a urinary tract infection. So let's take a moment to address these different answer choices. Let's go through them one by one. So the first answer choice is observation until the urine culture results. And so this is not appropriate because this is a febrile infant with poor feeding, with signs of dehydration on the urinalysis and based on the urine output. And we're concerned about a bacterial infection in this young infant. So it's not appropriate to wait until the urine culture results, which could take up to 24 or 48 hours. So that's not correct. Repeat the urine specimen collection with a sterile collection bag. So this is meant to be a distractor. This is trying to trick you by using the word sterile. In fact, the way the urine was collected with a catheterized urine specimen is the appropriate way to collect a urine specimen in an infant who's still in diapers. An infant who's still in diapers, you cannot use a bagged specimen because it might be contaminated. And of course, you can't expect them to be able to have a clean catch, a midstream clean catch, because they're only a 9-month-old. And so in infants who are still in diapers, we must use a catheterized urine specimen. So the way it was collected was actually appropriate, and this is a distractor. So this is incorrect. Answer choice C, obtain abdominal x-ray and stop feeds. So this is trying to lead you to think that there might be an underlying abdominal etiology to the patient's presentation. But overall, despite there just being one small episode of emesis, there are no other GI symptoms. There's no diarrhea, there's not repeated episodes of emesis. The abdominal exam is unremarkable, because they didn't comment on it in the answer or in the question stem. So this would be correct if we were concerned about an abdominal etiology, but here we're really concerned about a urinary etiology. So this is not correct. Answer choice D, obtain retrograde cystogram. So this is one of those answer choices that's also meant to be a distractor, where you see the word cystogram and you're thinking, hey, I'm not exactly sure what this study is, but it sounds like it could be right because it's relating to the bladder. And so because I'm not 100% sure, maybe I should pick this one. So in general, for these more advanced studies where you're not always sure what the study or even the procedure is, unless you're confident in your answer choice and you are familiar with it and you know it's the right answer, I typically recommend not choosing that because often these are just meant to be red herrings or distractors. So a retrograde cystogram would be useful in the setting of hematuria, for example, if we were concerned about bladder injury or trauma, but in the setting of a UTI, it's not part of the workup for a UTI. So this is incorrect. The next two answer choices include starting antibiotics and then performing some additional imaging study. So let's take a moment to talk about these additional studies. So D and E could both be correct. They both include starting antibiotics, which would be appropriate in a febrile infant with findings concerning for a UTI, but we need to determine which additional study is indicated. So let's take a moment to review the clinical presentation of UTI and the diagnosis and talk a bit more about these additional studies. So UTIs in infants, the common pathogens are going to be similar to the common pathogens seen in older children and adults, the most common one being E. coli, followed by Klebsiella and Proteus. So this is not surprising. The risk factors in infants include infants less than 12 months of age, females, because the anus is close to the urethra, so it's easier for those enteric pathogens to climb up the urethra into the bladder, and uncircumcised males. So our question stem included two of these risk factors. It was an infant less than 12 months and he was uncircumcised. So this was a really important clue. Whenever you see this in a question stem with a febrile infant, you should have a high level of suspicion for urinary tract infection. The other two are urinary tract anomalies, such as congenital anomalies, as well as vesicoureteral reflux. The clinical presentation in infants will be very nonspecific. It'll be fever, particularly fever above 39 degrees Celsius, which is what our patient had, as well as fever lasting 2 days or more. And these nonspecific findings we mentioned already, like fussiness, irritability, poor feeding. Again, this is not specific to UTIs. It just gives us a sense that the infant is ill or sick and that there may be an underlying infection or illness. The other potential features in the presentation are going to be the absence of another source of infection. So this was important. We highlighted that there were no upper respiratory symptoms, no coughing, no other GI symptoms that would make us think that this was a viral gastroenteritis. There's really nothing else on the history or physical exam to suspect another source of infection. And in infants, we may see decreased urine output, although it's not necessary part of the presentation. So if it's there, it can be helpful, but it doesn't need to be there to have suspicion for UTI. And really, it's going to be the presence of these higher fevers with the fussiness, irritability, nonspecific findings, and the lack of another source of infection. We should have a very high index of suspicion for UTI when we see these findings. In terms of the diagnosis, the UA will be helpful in establishing the presence of pyuria in the urine, so the presence of white blood cells. If there are 5 or more white blood cells, it's concerning for pyuria, as well as positive leukocyte esterase, which is associated with white blood cells, as well as nitrites. So these findings, which were present in the question stem, were very concerning for the presence of a UTI, but remember, there can be other things that can cause pyuria in the urine. So in order to make a final diagnosis, the most accurate method of making the diagnosis is going to be to establish the presence of bacteriuria, so the presence of bacteria in the urine. So this is the gold standard for the diagnosis of a UTI. And in infants, we must use a catheterized urine specimen. A bag specimen is not appropriate, a clean catch is not appropriate. We must use a catheterized specimen. And because it's catheterized, our threshold is going to be greater than 50,000 colony-forming units of a single uropathogen, and that can be E. coli, Klebsiella, Proteus, any of the uropathogens that we described previously. So although establishing the presence of pyuria is helpful in the diagnosis, the gold standard is going to be identifying and growing 50,000 or more colony-forming units of a single uropathogen. I do want to point out that if it's in older children, when we use a clean catch or sample, for example, a midstream, it would be 100,000. But because this is a catheterized specimen, we feel pretty confident that this is not a contaminated specimen. So we have a slightly lower thresholds. So you might see a different number when we're talking about UTI in older children or in adults. So you want to identify a single uropathogen using a catheterized urine specimen. So now let's discuss these advanced imaging studies in a bit more detail. So although this is not something we talk about in adult UTIs, in pediatric UTIs, we typically do some form of advanced imaging if the child meets certain criteria. So renal and bladder ultrasound is going to be indicated in all infants less than 24 months of age with their first febrile UTI. And this is going to be looking for those risk factors we identified, vesicoureteral reflux or other congenital urinary abnormalities that we might not have previously identified. So all infants less than 24 months of age with their first febrile UTI should get a renal and bladder ultrasound. So this is a really important point. The other indications are lower yield, but still worth mentioning. A child with a recurrent febrile UTI, so at least 2 or more febrile UTIs at any age, as well as a UTI in a child of any age that has a family history of renal or urologic disease, that has hypertension. So if the child has hypertension or if the child has poor growth, this would also be an indication. And finally, a child that doesn't respond to appropriate antibiotic treatment within 12 to 36 hours. So the highest yield point here that's most frequently tested is going to be this first indication, infants less than 24 months of age with their first febrile UTI. Now, what about the VCUG? VCUG is the voiding cystourethrogram. So this is one of those more advanced imaging studies that's going to be indicated if there are abnormalities that are identified on ultrasound. So this might be the presence of hydronephrosis or some other abnormality identified on ultrasound. In this case, we would go ahead and get the VCUG. But it's not going to be first line. First, we would always get the ultrasound. As well as a recurrent febrile UTI in any age, if there was a recurrent febrile UTI, we would get the ultrasound first and then the VCUG. So let's take a look at our last two answer choices. So we had narrowed it down to either D or E. So it would be appropriate to start antibiotics in this febrile infant where we're concerned about a UTI, and then the question is asking you to really hone in on that specific high yield point about what the next step in terms of imaging would be. And now that we've reviewed that, we see that answer D is correct. In this is a child with his first febrile UTI, and he's less than 24 months of age, so it would be indicated to obtain a renal and bladder ultrasound. Now, if this had been his second febrile UTI, we would need to get both of these, and VCG might be correct. But in this case, it's his first febrile UTI, so answer D is correct. So that wraps up our question of the week, and thanks so much for listening.